Okay, so in the previous session, we saw the difference between acute infective endocarditis and subacute infective endocarditis. Now I'm going on to the clinical features, and I'm just going to do exactly what I did in the previous session, which is separating and comparing acute and subacute in each slide. So we start with symptoms. In acute infective endocarditis, the patient would manifest with a sudden onset of fever, and they would have chills, and it progresses very fast, and in a few days, 2 to 3 days, there is valve destruction and half the cases die. And signs, because of large vegetations that cause turbulence, when you place a stethoscope, you would hear murmurs. And in course of days, some of the vegetations break up. So when they break up and fragment, the murmur changes in its nature. It can reduce in intensity when more blood goes through. And when there is a disturbance of valve leaflets, and because of that, there would be a disturbance of valve function. So there will be a cardiac failure. It could be due to left ventricular hypertrophy, or later on due to pulmonary hypertension. It would go on to right ventricular hypertrophy as well. And when the thrombi break up, they can lead to emboli, systemic emboli all over the body. In subacute bacterial endocarditis, the symptoms are minimal because these people already have an abnormal heart valve, and the bacteria that is causing the infection through bacteremia has a low virulence. So they would have very minimum loss of weight, which is due to cytokines, which also causes fever. And the disease slowly progresses, and the destruction of the valve is gradual. And there are a few murmurs, and because already the person has murmurs due to the cardiac lesion, but changing murmurs are very rare. And just like acute infective endocarditis, even in subacute, thrombi may lead to emboli. Now, immunological phenomena are very important in infective endocarditis. Some of these questions are commonly asked in competitive exams. Now, when there is an infective agent, for example, streptococcus or staphylococcus, there are immune complexes that are formed against the antigen, and these immune complexes circulate all over the body until it reaches small blood vessels beyond which it cannot move. And in those areas, it will cause petechiae. When it occurs beneath the nail beds, we call it subungual hemorrhage, and it is like small splinters. So they're called splinter hemorrhages. When it occurs in the eye, in the retina, they're called Roth spots. And whenever there is a hemorrhage in the retina, there is also exudate, and that in a retinoscope is seen as cotton wool exudates. So that is called Lytton sign. And the immune complexes can get trapped inside the capillary tuft in the glomerulus. If you remember, the capillary tuft is as small as the small capillaries in the capillary beds in the body. So the immune complexes can get trapped in the glomeruli, thereby damaging the glomerulus, causing fibrosis, causing thickening of the basement membrane, and hence glomerulonephritis. Now, in the previous lecture, if you remember, the first person to have discussed about infective endocarditis in detail was Osler between 1885 and 1915 for 30 years. And he is the main expert in infective endocarditis. And this was also his description, Osler's notes, and hence named after him. These are small, tender red to purple nodules. They are in the pulp spaces. Okay, it lasts for a few days, and in 2 days it loses its tenderness. Tenderness means painful. Now this also, the reason is because of immune complexes which we saw in the previous slide. So when you see it microscopically in a biopsy, you would see vasculitis, blood vessels inflamed, surrounded by neutrophils, and lots of small micro abscesses. And the micro abscesses suggest bacterial proliferation. Now we need to distinguish Osler's note from the next lesion, which is Janeway's lesion. Now Janeway's lesion usually occurs here and here in the thenar and the hypothenar eminence of the hands and feet. So it is here. This can occur even in the feet. Now these are erythematous red and painless macules, flat areas, while Osler's nodes are painful and enlarged. These are painless and flat. And these are also because of infectious vasculitis, usually related to Staphylococcus aureus infection. So remember to distinguish between Osler's node and Janeway's lesions. Look at my hand. Osler's nodes occur here and here. Janeway's lesions occur here. The same thing in the feet. Osler's nodes occur in the toes and Janeway's lesion occur in the thenar, hypothenar corresponding area in the feet. Now these are Osler's nodes, raised and painful in the pulp spaces of the digits. These are Janeway's lesion, flat. Here are some more pictures to help you understand the immunological phenomena. These subungual hemorrhages, they look like a splinter, so they're called splinter hemorrhages. These are Osler's nodes. These are Roth spots, and these are Janeway's lesions. This clinical picture shows subungual hemorrhages shaped like a splinter, so these are called as splinter hemorrhages. Another close-up view of splinter hemorrhage. Another picture of hemorrhage in the form of splinters. Another clinical picture of a Janeway's lesion. Now all this should help you understand the various immunological phenomena. Osler's nodes in the pulp spaces of the fingers, painful, red and raised.